As you can see here on the left side with my mouse, we have introduction, typical history station, and atypical history station. When you press here, you will have subtitles. This is a timetable, how to use a school, and what is the school. This will give you an idea about this new app. And then you have the typical history station here, which includes all these stations. And then you have atypical history stations, which include these. All right, we're going to start today with the typical one. We'll start with the infected pseudoaneurysm. The scenario will be a 45-year-old man who has a lump in his groin, probably in the first step. Hello, my name is Ali. I'm one of the surgical doctor working here. We said don't say I'm one of the exam candidates. Try your best to mimic the exam. So I'm one of the surgical doctor working here. May I confirm your name and age, please? We wrote this like we are not trying like this is not the exam sentences, but we're trying to mimic the situation in real life. So this is our effort to make it easier for you guys. Hi doctor, then he will reply to you. Nice to meet you, Mr. John. He said his name is John. And I see like a couple of students miss this point. They will forget the patient name and they won't mention the patient name. Believe me, I cannot emphasize this enough. Mention your patient name. This will give you marks. This will show you are a master. This will show you are experienced. This will show you are a good clinician. And as you're going to see in this course, we will mention our patient name a couple of times. All right? I will be your doctor for today. I want to ask you a few questions regarding your condition. Are you okay with that? You need to take the consent. So the examiner will mark you because you introduce yourself and you took your permission. How can I help you today? Then he will tell you that he has a lump in his thigh. When he tells you that he has a lump in his thigh, don't forget to say, I'm really sorry to hear that. This is very important. And when you say it, don't say, I'm really sorry to hear that. I'm really sorry to hear that. No. Change the tone of your voice. Say, I'm really sorry, Mr. John. I deeply understand. I'm really. Change the tone. All right. As you can see here, analyze the main complaint using Socrates. So, and I'm going to give you a trick. In every single main complaint, you can use Socrates for the details of your complaint. So Socrates is not just for the pain, for any complaint. Even for a problem in your life, you can use Socrates, by the way. What's the site? What's the onset? What's the course, duration, character, irradiation, timing, severity, aggravating factor, relieving factor. So Socrates is not just for pain. Socrates for any complaint. If you want to analyze everything in life, you can analyze it using this. Even your MRCS OSCE exam, where the site of the exam, onset, when, duration, character of the exam, how you're gonna study for it. So I use Socrates for the life. Where exactly is the lump located? So you're gonna start with the location. And as you can see here, we said where is the lump exactly located, Mr. John. So we mentioned the patient name. I'm sure you may think this is a very minor point, but believe me, when we start practicing, you will see that like a couple of students don't mention the patient name, and the examiner will notice that, except specifically if he is working in UK. Then he will tell you the location. This is not important. We just we created this module on the top of my left side. Look, I see. Try like you are replying to the patient. You are communicating to the patient. So it's not just the patient talking to you and you just silent. No, I see. When did you first visit that lump? 5 days ago. Did it start suddenly or gradually? Then you will ask this question. Does it come and go? You want to complete this right? Character severity. And then, have this changed recently? Is there any specific time during the day the lump increases in size? Is the same throughout the day, getting bigger day after day? If there anything make the lump increase in size? Yes, time. We tell you like it's progressive by time. If anything make the lump decrease in size? No. Is it reducible or no? Does it increase by cough or no? So you will ask, is there anything increasing? You don't want to ask, does the lump increase when you go to the toilet? Does the lump increase when you cough? Does the lump increase when you exercise? No. like, is there anything increases the lump? That will contain all these questions because you don't have time. And then you're going to do your differential diagnosis. The first differential diagnosis, and this is probably going to be your main diagnosis, is infected femoral pseudoaneurysm. And to know it's infected, the first thing you'll ask, is it painful? Because every abscess or pseudoaneurysm or infection is going to be painful. He will say yes. Whenever your patient say he has pain anywhere in his body, analyze the pain using Socrates. Regardless of the station, is there any pain? Yes. Then immediately analyze using analysis, using Socrates. Mr. John, why exactly do you feel the pain? He will tell you why exactly. When did the pain first start? Look. I really want to emphasize this, Mr. John. We mentioned the patient name. Mr. John, how hard the pain came or developed since it began? It's getting worse gradually, he will tell you. How long does the pain typically last? Is consistent. How would you describe the type of the pain? Is it sharp, dull, and stabbing? And when you ask this question, how would you describe the type of the pain? Make sure you mention the type of the pain that you are aware of. Sharp, dull, and stabbing. Don't make it blunt. Your patient may not know. Mr. John, look, does the pain spread to any other areas? No. Is there a specific time of the day or activity that trigger the pain? He will say, I don't know, or he will tell you an activity. As you can see, you cannot mention your patient name in every single question. So just mention a couple of times. Mr. John, does the enemy make pain worse or better? Okay. Memorize this sentence because you're going to need it in multiple stages. On a scale of 1 to 10, with 10 being the worst pain imaginable, how intense is the pain? Memorize this sentence because you're going to use it. Have you noticed any other symptoms that associated with the pain? You'll tell you, I feel sick because probably he's infected or septic. Mr. John, did you have any recent injection or trauma in your groin? And probably that's the cause because you are suspecting the main cause of his pseudoaneurysm is the injection. He will tell you yes, and he may tell you no on the exam. So be prepared. Maybe your first differential is not the differential that you are searching for. We are not trying to make you memorize. We are trying to create doctors here. So don't memorize it's going to be an infected pseudoaneurysm. It could not be. It could be another differential. Okay? And you know, okay. Here, Mr. John Pearson, yeah. Do you feel this swelling beating? If it's beating, that means it's arterial, right? Because do you feel any limb pain or coldness, color change, or limb swelling? And why are you asking this question? Because if he has pseudoaneurysm, that means the blood supply to the lower legs will be affected. That's why he will have limb swelling and color change. Do you have any limb numbness? That means there's neurological symptoms here. Then your second differential is growing abscess. All this question is for infected pseudoaneurysm. Your second question is growing abscess. Mr. John, have you been ill or have fever? Fever is a cardinal feature of infection, of inflammation, right? Is there a wound or sore over the lump? You will say no, probably. Did you notice any discharge from the lump? Just blood sometimes. If the patient said, yes, I have fever, and there is a sore above the blood, and also there is a yellowish discoloration coming out of the blood, then your differential will be growing abscess. Okay? So be careful. Don't try to memorize. Understand. Do you notice any discharge from the lump? He said just blood. Your third differential is lymph node. Is it inflammatory due to infection or neoplastic? There is a metastasis from whatever. Mr. John, how has your appetite been? Because if his appetite is decreased, this could be a neoplastic problem. Have you noticed any unintentional weight loss? Always ask about the weight loss because we have so many differentials that contain malignancy. So we want to differentiate any malignancy. Your fourth differential is inguinal hernia. Mr. John, have you noticed the lump increases with the straining while passing urine or stool? If the lump is increasing with the straining, that means it's a hernia because it does increase with the increasing with increased intracranial pressure. Have you noticed that the lump decreases in the size when you lie down? If yes, that's probably a hernia. Mr. John, do you have tummy pain? Because if you have a hernia, then you may have transient intestinal obstruction. And then the patient will feel the pain. And then when the obstruction relieved, the pain will be relieved. So you're asking about the pain because of the obstruction. Did you throw up? Because vomiting also is a sign of obstruction. Do you have a distension or bloating? Because you want to check the differential diagnosis. And this is the most important part. The differential diagnosis in the history is the most important part. Now you finish your differential, infected pseudoaneurysm, growing abscess, lymph node, inflammatory or neoplastic, and inguinal hernia. You will go to the past medical history, which is similar for most of the stations. Did you experience similar symptoms before? So the past medical history is the most important. Did you experience similar symptoms in your past? You will say no or yes. Do you have any other medical condition? He will say no or yes. If he said he has medical condition, you will ask him what do you have? You will say diabetes or hypertension or stroke. You will ask him what medication are you taking? Don't forget to ask about any surgeries. And surgeries is very important here. Why? Because one of your differential is inguinal hernia, and you want to know if there's any incisional hernia before, or if there's any obstruction due to adhesion. Then you will go to drug history, and you will notice we follow this system in all the schools. So I want you to memorize this. Do you take any medication? You will say yes or no. Do you have any allergies? Yes or no. Allergies is very important, especially when you come and work here in UK. This is very important. So many allergies, and it's quite critical and important to ask about the allergies. Family history. Is there anyone in your family complaining about the same? You will say no one I'm aware of, or yes, there's someone. As you can see, we include Mr. John. So we left it for a couple of questions, but we added here. Mr. John, I would like to ask you a personal question. Is that okay with you? Whenever you ask social history, don't forget to ask this question. Very important. Because he may not wish to discuss anything with you regarding his social life. If he said, let's say, you said, I would like to ask you a personal question. Is that okay with you? And your patient said no. You will say, the patient refused to answer any social history questions. You will just mention that. But probably he will say yes. Mr. John, what do you do for living? Yes. What do you do for living? I want you to memorize this. Or, Mr. John, what is your occupation? Or, Mr. John, what is your job? Memorize this. I'm a teacher or whatever. Who lives with you? My wife and my son or my kid. Nice to hear that. Look here. Okay. You are living with your family. Nice to hear that. And you can ask him what's the name of your son if you think you have time, just to make sure that you do, like, if you think you are very excellent and you master the history, you can ask this question, like, what's the name of your son? Oh, how old is he? Do you have any difficulty with the stairs? This is a very important question here. We ask this question because this may lead us to change the house of the patient, or to ask the occupation health to see the patient. Occupational health to see the patient. We call it BT and OB, physiotherapy and occupation. Do you smoke? If you forgot like the social history, the most important question in the social history is, do you smoke? That's the most important one. You should not forget that. And when he tells you, I smoke, you need to know exactly how many cigarettes per day for how long. Do you drink alcohol? That's the second important question. Okay, then if you have time, of course, you will ask about the idea, concern, and expectation. Before I go any further, could I ask you what you think the cause is? He will tell you. Mr. John, what are you the most concerned of? This pain. And what are you hoping from us to do? He will tell you, fix the pain. If you have time, you can say this. Thank you for sharing your idea and concern. If you have time. If you don't have time, you immediately need to jump to the systemic review. And in the systemic review, you just ask two questions. Mr. John, is there any headache? No. Is there any chest pain or shortness of breath or cough? No. Any problem passing urine? No. Any muscle or joint pain? Anything else you want to add? Just like quick question. The eyes will give you, like, you will be more professional if you ask about this, and if you ask about the systemic review. But if you don't have time, this will not reduce your marks. If you don't have time, this will not reduce your marks. That's why I leave the eyes and leave the systemic review at the end. And then you will start the discussion. Present. That's the first thing the examiner will ask you. Present your patient. And I was surprised that so many students don't practice this. You have to memorize this. You have to practice to present your patient, because this is the first interaction between you and your examiner. You have to master this. You have to master your presentation. And as you know, we created these videos to help you guys. There's a video here you can watch from A to Z. I wanted to watch this video, for example, when you are going to the gym, or when you are playing, or you are driving your car, or whatever. It will give you an idea. So practice presenting your patient. Present every single patient. Then your examiner will ask you what's your differential diagnosis, which is already up there. How will you investigate your patient? You will say after doing full clinical examination, including. So I'm going to mention the presentation because we're going to take the recording also. I took a clinical history from this gentleman, Mr. John, 45-year-old, who is referred to us as a groin abscess. He complained of a progressive painful lump in his left thigh for 5 days. The lump is versatile. That's why you think it's pseudoaneurysm. And discharges blood sometimes. He's allergic to penicillin. He drinks alcohol, smokes cigarette, and self-injects drug. That's the cause. That's very important. He has no weight loss or family history. That's why it's not a malignancy or of a similar condition. No symptoms suggestive of hernia, because that's a very important differential. So my main diagnosis is infected femoral pseudoaneurysm. So you mentioned the important positive and the important negative. That's all. Important positive and important negative. And you have to train yourself to present. What's your differential diagnosis? Inguinal hernia, groin abscess, femoral hernia, testicular cancer. How will you investigate your patient? After doing, remember this, in every investigation, after doing full clinical examination and taking history, including lab, abdominal, and lymph node examination, I will request the following: blood investigation, including full blood count, urea and electrolyte, and liver function test. Full blood count, this is a mistake here, I'm going to correct it now. It's full FPC, it's not the FPC. Let me do that now. So you do full blood count, which is hemoglobin and electrolyte and all the blood tests. Full blood count, and then imaging, duplex ultrasonography, CT and angiogram. How will you treat your patient? I will discuss the patient history, examination, and investigation in the MDT meeting. Every department has MDT meeting room. MDT is a very big thing in UK. So mention this in every single treatment. Okay, then you should say the treatment choices are, even though I'm going to discuss it in the MDT meeting, but I know the general idea. Non-operative treatment include analgesia, antibiotic, after culture and sensitivity, and according to the hospital policy, because duplex ultrasound, guided compression, and percutaneous thrombin injection. Operative treatment, ligation of the import artery with delayed revascularization. Then the examiner may ask you about defined pseudoaneurysm, a collection of blood that form between the two outer layer of an artery. So the pseudoaneurysm and the true aneurysm, the difference between them is that the pseudoaneurysm, the blood just goes through the tunica media and tunica intima and tunica media, but the blood doesn't go through the adventitia. But in the true aneurysm, the aneurysm goes through all the layers. That's why we call it true aneurysm. Define aneurysm. Aneurysm is abnormal dilatation 1.5x the normal origin.
This image here describes the difference between true and false aneurysm. On your left side, you have the true aneurysm with two types, saccular and fusiform. All the layers of the artery, including tunica intima, tunica media, and tunica adventitia, are bulked out in the true aneurysm. As you can see on the right side of the picture, there is pseudoaneurysm, false aneurysm. Not all layers of the artery are bulked out here. It's just the tunica adventitia. Tunica intima and tunica media are not bulked out. There's a difference between the true and false aneurysm. At the end of each history station, you will find this table. You have your differential on the left side and the question that you need to ask on the right side. We created this to help you to remember the differential diagnosis, which is the most important part in the history.
After this session, let's say you are studying yourself and it was like this. I want you to do this. And I want you to open the video from here and watch it from A to Z a couple of times. It will give you an idea about how to take the history with the discussion. Good. Let's
Now,
go to the next
let's
station.
tackle the next station, which is the rectal bleeding. You will have your scenario, which is an elderly man who has or presented with bleeding per rectum. Firstly, introduce yourself and take permission. You will have mark for that. Hello, my name is Ali, John, Muhammad, Khalid, Ahmed. I'm one of the surgical doctors. We said, don't say I'm one of the exam candidate. I'm one of the surgical doctors working here. May I confirm your name and age, please? He will tell you your name, then say, nice to meet you, Mr. John. I will be your doctor for today. Are you okay with that? You have to take permission. You have a mark for that one. Some students forget to take permission. Don't ever forget to take permission. When he tells you his problem, I have bleeding per rectum or whatever, you can say, I'm really sorry to hear that. And when you say that, please change your tone. I'm really sorry. Don't say, I'm sorry. No, say it in a way that's convenient. I'm really sorry to hear that, Mr. John.
Analyze the main complaint by Socrates. Did it start suddenly or gradually? The site, of course, is the rectum, so it's coming from the back body. Did it start suddenly or gradually? I'm not sure, but it's getting worse. When did you first notice the pain? Notice the blood? 2 months ago. This, like we did create this, but it could be 2 months ago, it could be 1 year, it could be 2 days. It doesn't matter basically. Does the bleeding come and go? No, it's consistent for this scenario. Did it get worse? Yes, it's getting worse. Look, what is the color of the blood? You want to know, is it black or red pride? Because if it's black, this means it has been there for 2-3 days. If it's red pride, this means it's a new blood. How much blood you notice every time? This is very important. The quantity of the blood. Any clots? We ask about the clots just to make sure that if the clots will give you an idea about the amount of the blood. Is that bleeding painful when you pass a stool? Because you want to differentiate anal fissures and thrombotic hemorrhoids. Thrombotic hemorrhoid also will make pain. We will say no pain, or if there is any pain. Is there anything that makes this bleeding stops? Is there anything that makes this bleeding increases? Then you're going to go to your differential. That's the most important part. First differential, colon cancer, because of his age and his presentation. Do you have any other disturbance regarding bowel habit besides constipation, Mr. John? He said no. He could have diarrhea, by the way. So if you have alternating diarrhea, alternating diarrhea and constipation, that's a different differential. How has your appetite been? That's the most important question for any malignancy, as we said. Always ask about the appetite and always ask about weight loss. Have you noticed any unintentional weight loss? Because you may lose weight intentionally. For example, if I want to lose weight now, I can do that intentionally by decreasing my calories. So you need to know, is it intentional or unintentional? How many kilos and for how long? That's a very important question. Because if he lost 10 kilos in the last 3 months, that's very significant. But if he lost 1 kilo in 2 years, that's nothing. So not every weight loss is worried. You're done with your first differential. Your second differential is IBS, irritable bowel syndrome. Have you noticed any slime or discharge? No. Does the pain relief after opening your bowel? Does the pain get better after you open your bowel? Probably not. If the pain getting better when he opens his bowel, that means IBS. Then IBD, inflammatory bowel disease. Have you had any mouth ulcers? As you know, Crohn's disease is from the mouth to the anus. So if he has Crohn's disease, specifically not ulcerative colitis, probably he will have mouth ulcers. Any fever, because it could be infected. Any painful red eyes, which is extra-intestinal manifestation of inflammatory bowel disease. Any painful red eyes. Any joint or back pain, also extra-intestinal manifestation of IBD. Any skin problem, extra-intestinal manifestation of IBD. Then this is one of the most differential, bleeding tendency. Have you noticed any bleeding from any other orifices? If he has a bleeding from any other orifices, this means the problem is not a colon cancer problem. Maybe he has von Willebrand deficiency or whatever, coagulation cascade deficiency. Maybe he has bleeding tendency. So ask about bleeding from other orifices. Also, gastroenteritis. Have you been abroad recently? No, because probably gastroenteritis will happen when you travel. Do you vomit? Gastroenteritis, as you know, present with vomiting. Do you have any tummy pain? There is no gastroenteritis without abdominal pain. Then you need to ask about the anal causes. Have you noticed itching around your back passage or any swelling? They will say no. There is a very important question. We can ask about it here or we can ask about it in drug history. Do you take any blood thinners? That's very important. Either we ask about it in the differential, which I prefer. That's why I'm going to add it here. Or we can ask about it when we are doing the drug history. So you have two choices. The sixth differential you add is medications. So this is a very important question you need to ask your patient. Do you take any blood thinners or no? If he's not taking blood thinners, probably the cause is not his the cause is not a medication. All right. Then, as we did before, we're going to ask about the past medical history. Did you experience similar symptoms before? Do you have any other medical condition? What do you take for it? Here he said he has diabetes and he takes metformin. Have you had have you ever had surgeries before, Mr. John? That's very important. Then family history. Family history here is more important than the previous station. Why? Because colon cancer runs in the family, right? You know, hereditary non-polyposis colorectal cancer. So it's an autosomal dominant. Colon cancer is very important to ask for family history. Here is more important. If you forgot it in the previous station, you may lose 1 mark. But if you forgot it here, you may lose 3. That's very important. Is there anyone else in the family who has had a similar problem? My dad died of colon cancer. Look, imagine if you miss that in the exam. You're gonna be in a bad situation. I'm sorry for your dad loss, Mr. John. Look here. My dad died of colon cancer. Some of you guys will just let it sleep. My dad died of colon cancer. Do you take any medication? Imagine someone tells you his dad died, and your next question is, do you take any medication? That's so bad. You should say, I'm really sorry for your dad loss, Mr. John. I'm really sorry for your dad loss, Mr. John. You have 4 marks here in a sentence like this. Do you take any medication besides metformin? Here we want to know if he take any blood thinners. Okay. Do you take any medication besides the metformin, Mr. John? Do you have any allergies to any drug? Penicillin? Okay, I see. Then social history. Do you mind if I ask you personal question? You have to ask this one, as we said before. What do you do for living, or what's your job, and what's your occupation? Who is at home with you? My wife and my youngest daughter. Do you have any? If you have time here, you can say how old is she, or you can say what's her name. But if you don't have time, you don't need to. Do you have any difficulty with the stairs? The stairs is important. Do you smoke? That's the most important question. Do you smoke? He said yes. Then you're gonna ask him how many bags per day. He said 1 bag a day for 20 years. If he didn't say for 20 years, we will ask him for how long, but he already mentioned it. Do you drink alcohol? Yes or no? It's not important. Then you ask him about idea, concern, and expectation. As we said before, what do you think the cause is? What's your concern? And what's your expectation? Then you're gonna finish with the systemic review. Do you have headache? Do you have any chest pain? Do you have any shortness of breath? Do you have cough? Okay? Don't forget to thank your patient at the end. Thank you, Mr. John, for your cooperation. I will discuss this with my consultant or with my senior, and I will get back to you. Memorize this. Memorize this.
The most important thing is to train and practice how to present your patient. So in this case, you can say, I took clinical history from this gentleman, Mr. John, 73-year-old, who presented with rectal bleeding. That started 2 months ago, and it's worsened lately. He has constipation, weight loss, and loss of appetite. He has no symptoms suggestive of inflammatory bowel disease, gastroenteritis, or anal disease. He has family history of colon cancer. He smokes 1 pack of cigarette a day and drinks 4 units of alcohol per week. As you can see here, you can use medical term when you're speaking to your consultant because he's a doctor. What's your differential diagnosis? Firstly, colon cancer, and then gastroenteritis, inflammatory bowel disease, bleeding tendency, and anal causes like anal fissure and hemorrhoids. What's your most important investigation? You should say, as I'm suspecting colorectal cancer, the most important investigation is a colonoscopy plus or minus biopsy to examine the whole colon. What are the other investigations that you can ask for? You can ask for stool analysis, blood investigation, including full blood count to estimate hemoglobin and white blood cell, and you can ask for biochemistry like urine electrolytes, UNEs, liver function test. And why we ask about liver function test? If your patient has hepatic failure and cirrhosis, for example, he may have variceal bleeding, or your patient may have malignancy. Arterial blood gases to check for raised lactate if it's ischemic, and metabolic acidosis. ECG to exclude mesenteric ischemia and atrial fibrillation. Endoscopy, OGD, to exclude upper gastrointestinal cause, because if you have upper gastrointestinal bleeding, a huge amount of blood may come out in the back passage as per rectal bleeding. So if you have a bleeding from upper GIT, that can lead to lower GI bleeding. Sigmoidoscopy, proctoscopy to detect hemorrhoids, anorectal lesion, distal colitis, and rectal ulcer. Radiology, like abdominal X-ray to detect for any obstruction. In the obstruction, you will find multiple air fluid levels, toxic megacolon, or inflammatory bowel disease. You may also check and do ultrasound and CT. CT if you suspect malignancy, to check for liver metastasis and to do staging. And lastly, mesenteric angiography, including CT or invasive technetium scan, labeled 90 red cell scan, if your source is not identified by endoscopy. How to treat this patient? You should say, after doing full clinical abdominal examination, including digital rectal examination, I will discuss its patient history and examination in the MDT meeting. We said MDT is a must mention it with every single treatment. Then I will stage the tumor, and I will classify to operable and non-operable. If it's operable, I will consider Hartmann procedure with end ileostomy. If it's not operable, I will consider palliative treatment. Then your examiner will say, thank you, doctor, you can continue to the next station. As we said, and we are giving a disclaimer here, this is not exactly the question in the exam. This is our best to try and simulate how the exam will be conducted. And I'm doing this disclaimer for legal stuff. So this is a clear disclaimer. At the end, we created for you a couple of important questions, which is the differential diagnosis and how to ask about each differential diagnosis. You can see the image, how to ask about colon cancer, IBS, IBD, and this is available on our course in the school. You can access it immediately. Let's go to the next station.
Okay, irritable bowel syndrome. Your scenario probably going to be a female was referred by her GP as having chronic calcular cholecystitis. Start by introducing yourself and take permission. You will have a mark for that one. Hello, I'm Dr. Iman, one of the surgical doctors working here. As we said, don't say I'm one of the exam candidates. Do not say that. Say I'm one of the surgical doctors working here. May I confirm your name and age, please? She will tell you her name. My name is Anna, for example. I'm 46-year-old. Nice to meet you, Anna. I will be your doctor for today. Can I ask you a few questions regarding your condition? Can I ask you a few questions? Are you happy with that? All of these are good alternatives. This is a permission here. You will have marks for that. How can I help you today? She will tell you I have a belly pain, for example. Then, if I told you I have a problem, you need to be sorry for me, right? Here the communication marks. I'm so sorry to hear that, Anna. Analyze the main complaint using SOCRET. Site, onset, course, duration, characterization, timing, severity, aggregating a relieving factor and associating factor. Could you point to the file, please? Yeah, it's all over my stomach. I see. So you are communicating with the patient. You are not a robot.
When did you first notice that pain? A long time ago, around 9 months. Had this changed recently? Yeah, it became more frequent. Miss Anna, look here, we mentioned the name again. Does it move anywhere? No. Is there anything that makes the pain stops? Yeah, when I visit the toilet, which is characteristic for irritable bowel syndrome. Is there anything that makes the pain increase? Yeah, for example, let's say after the meals. Could you please describe the pain for me? Is it colicky, cramping, or stabbing? She said cramping. How badly is this pain affecting your day-to-day life? Here you want to know the functional measurement of the pain. She said, I no longer enjoy my food because I know the pain will follow. If you had to rate your pain from 0 to 10, with 10 being the worst pain you could imagine, how much you would rate it? She said 8.
Then you have the differential. The first differential is IBS, irritable bowel syndrome. If the tummy pain relieved by passing stool, yeah, and she already mentioned that for you earlier. You just confirm here. Did it increase when you are stressed? Yes. IBS increases stress. Do you have bloating? Yes. As we said, don't memorize, just understand. Your patient could have IBS or could be a different diagnosis. So you need to understand the process. Irritable, the second differential is inflammatory bowel disease. Have you noticed any slime or discard? No. Any pain in your tummy, especially with bowel opening? She said no. Do you have any disturbance regarding bowel habits? She said, what do you mean? Maybe she didn't understand what you're saying. In this case, you need to explain. I mean, is there any constipation or diarrhea? Have you had any of these: mouth ulcer, fever, painful red eye, joint or back pain, or skin problem? Ask about these separately. Don't ask about all of them together. So have you ever had mouth ulcer? No. Fever? No. Painful red eyes? No. No, luckily, not a single one. Your third differential is malignancy. As we said, for malignancy, you can ask by asking about the appetite. How has your appetite been? It's the same, no change. That's what she said. Have you noticed any unintentional weight loss or general tiredness? She said no. These two will give you an idea and exclude or include malignancy. Your fourth differential, gastroenteritis. We asked about this before, if you remember, in the previous station. Have you been abroad? Do you have any urge to pass stool despite passing a small amount? Your fifth differential is biliary colic. Okay, this is very important, biliary colic, because your patient was transferred to you because the GP was suspecting chronic calcular cholecystitis. Does the pain move to your right shoulder? Have you noticed the pain increase with fatty meals? Have you noticed yellow discoloration of your eyes? The patient, for all this question, she said no for the first question. Does the pain move to your right shoulder? She said no. Have you noticed the pain increase with fatty meal? She said yes. If the pain is increases with fatty meal, that doesn't mean it's biliary colic. If you have one or two answer for a differential, that doesn't make your differential the appropriate diagnosis. Have you noticed the yellow discoloration of your eyes? She said no. If she has yellow discoloration of the eyes and the pain is moving to the shoulder, a Murphy sign is positive, and the patient has the pain is increased with fatty meal, then your differential will be biliary colic at the start. So I'm not trying to make you memorize anything. I don't want you to memorize anything. I want you to understand what's going on. Because this differential is IBS, your patient will have IBS. The next exam, it could be IBD if your patient has constipation, alternating with diarrhea, mouth ulcer, fever, painful red eyes, joint or back pain, and skin problems. It's not IBS, it's IBD. So don't memorize anything. The station could be changed. Past medical and surgical history. As we said in the previous one, about did you experience similar symptoms before? That's the first question. Do you have any other medical condition? If your patient said, for example, I have diabetes, you need to ask, do you take any medication? Then they will tell you the medication that they are taking. Do you have allergies? Allergies is very important. Have you had any surgery before? Here, she had appendectomy, which is not significant here when she was 16, but you need to ask about it anyway. Family history, if anyone in the family complaining about the same. Social history, as we said, always ask about, do you mind personal questions? Are you okay if I ask you personal questions? What is your occupation, or what is your job, or what do you do for living? Who is at home at you? My husband and my daughters. If you have time, say, oh, really, that's nice. If you don't have time, just go to the next question. Do you have any difficulty with the stairs? Very important. Smoking? Yes. Do you smoke? How many packs per day? 2 packs a day for 10 years. If she didn't mention that for 10 years, we will ask her for how long. Let's say I asked her how many packs per day. She said 2 packs a day. I need to know for how long. Do you drink alcohol? Yes or no? Idea, concern, and expectation, as we said, if you have time, that's fine. If you don't have time, they will not reduce your mark. Systemic review, start from the head to the toe to make it easy for you. Just ask quick question. Do you have headache? Do you have chest pain, shortness of breath, cough, any problem passing urine? Just quick question to make sure that you cover the systemic review. If you are in the exam and the 6 minutes didn't pass yet, and you didn't hear the bell ring, because you will go to the station, you have 6 minutes, and then the bell will ring, which means 6 minutes passed. If you still have time and you have to choose between idea, concern, and expectation and systemic review, go with the systemic review. Ask about the systemic review first, then the IPS, then the eyes. Discussion, as we said, make sure you practice this. You have to make sure that you are practicing this. I took clinical history from this lady, Anna, who is referred to us as having chronic calculus cholecystitis. She's complaining of gradual abdominal pain and bloating. Her symptoms are relieved by passing stool, which is significant, which is textbook of irritable bowel syndrome, and exaggerated by stress and food. She has no jaundice, no symptoms suggestive for IBD. She smokes 1 pack a day, and she has no family history of similar condition. What are your differential diagnoses? Gastroenteritis, IBD, and biliary colic. That's the most important one. How will you investigate your patient? I will do full clinical examination. We said always mention this one. And then I will request the following: blood investigation, full blood count to estimate hemoglobin and white cell count, inflammatory markers, specifically CRP, C-reactive protein. Imaging, I'm going to do abdominal ultrasound, abdominal X-ray, colonoscopy, and stool analysis. How will you treat this patient? As we said, always say, I will discuss her in the MDT meeting. And then the general approach is lifestyle modification, fiber diet, and stress management, antispasmodic, antidepressant.
Don't forget to mention, refer the patient to the social worker. This is the most important part. It's very crucial here. Social worker is a crucial part in the management. And at the end, you will find the table This will help you memorize every single differential and how to ask about them.
I want you, when you finish, to make sure that you tick it. So it will appear on our system that you studied this one. So if it's this color on your side, when you study it and practice to someone, press on this one. And as you can see, your percentage will increase on this side.
Before going deeply in this station, as I mentioned, I would like to mention 5 important concepts. And by following this concept, you will get the full mark of communication skill, which is the 4 mark. I need all of you to understand and keep it and practice on it. It will help you in every clinical station of MRCS Part B, not just history, also examination and procedure, and even the communication skills. The first concept, when you knock the door and enter, please greet the examiner and the patient. Introduce yourself and confirmation the patient name and age. The third thing, explain what you're gonna do and take permission. The fourth one, be empathy and feel sorry for a patient compliance. And the fifth thing, and the last thing is to thank the patient at the end of the session. Footballer had a right knee injury a while ago. He had an operation that he had no idea about. Developed right worsening knee pain 1 month ago. From this scenario, my top differential diagnosis will be osteoarthritis. Why? Because this is a patient having right knee injury a while ago, and he had history of surgery. All right? The first thing, introduce yourself and take permission. Hello, I am Ali, one of the surgical doctor working here. May I confirm your name and age, please? Here you introduce yourself. My name is Adam. I am 56 years old. Nice to meet you, Mr. Adam. I will be your doctor today. Is that okay with you? This is the second concept, which taken permission. Yes, go ahead, doctor. How can I help you? I have pain in my right knee. And this is the third concept, which show empathy and feel sorry about the patient compliance. I'm so sorry to hear that. Don't worry, you are in safe hands. In this analysis of the main compliant while using Socrates, Ali said previously about this secret. I try to use Socrates as a structure for most of the main compliant analysis in all history stations as can as possible to make it easy to remember. Thus, my advice is to try to use it because exams are a matter of time. You will not have time to search for questions. So, Socrates, Mr. Adam, where did you feel the pain? Where did you feel that pain? Could you please point to it? The pain is mainly in my right knee. It's been bothering me a lot lately. Onset. In the onset, you have 3 questions. When did you first notice this pain? Did it start suddenly or gradually? Did it come and go? When did you start first? When did you first notice this pain? I first noticed this pain about months ago. Did it start suddenly or gradually? It started gradually. It was not too bad at first, but it has been getting worse recently. Mr. Adam, also you need to mention the patient name couple of times. Mr. Adam, did it come and go? Initially, it would come and go, especially after physical activity. The pain usually gets worse in the evening and at night, but recently it has been persistent and does not really go away. Here you finish the site and the onset. You have to ask about the character of the pain. Could you please describe the pain for me? Please, when you ask about the character of the patient of the pain, don't say just could you please describe the pain. Clarify more. Give the patient explanation by what you mean by description of the pain. Could you please describe the pain for me? Is it colicky, cramping, or stabbing? If you say just, could you please describe the pain for me? The patient may ask you, how can I describe it? And you will lose your time. So clarify more about your question. The pain feel more like a deep, okay, and sometimes a sharp stabbing sensation, especially when I move my knee. Does the pain move to any side? which is a radiation. No, the pain stay in my right knee. It does not seem to move other areas. There is association. So is there anything that make this pain stop or anything make that pain increase? Resting and avoiding putting weight on my right knee helps to ease the pain a bit. And the question is there anything that makes the pain increase? Walking or climbing stairs tend to make the pain worse. As I mentioned, you need to mention the patient name a couple of times. Mr. Adam, how badly is this affecting your day-to-day life? This is the most important question. It's a crucial question. The examiner loves this question. How badly is this affecting your day-to-day life? It's been quite challenging. The pain makes it difficult for me to walk comfortable, and I have had to cut back on activity I used to enjoy. Thanks. That must be hard, Mr. Adam. This is a point for empathy. Also, if you mention it, you will take a mark for communication skills. If you had to rate the pain from 1 to 10, with 10 being the worst pain you can imagine, how would you rate it? This is the scale of the pain. I would rate it around 8. It's quite painful and really impact my daily life. Oh, I deeply understand that. I deeply understand that. In the differential diagnosis, I have a secret also for this differential diagnosis. You need to categorize your differential diagnosis into 4 parts, which is malignancy, infection, inflammatory or autoimmune, and trauma, which will help you to memorize the differential diagnosis. From the scenario, I put the osteoarthritis as the top differential diagnosis. So in the osteoarthritis, there are main questions you need to ask about it. Mr. Adam, did you notice any worried noises when moving your knee? Yes, doctor. This is a crepitus. Crepitus is a sign of the osteoarthritis. Second question, did you notice any change in the shape of your knee? Inflammation, edema, that lead to change the knee shape? Yes, I noticed change in the shape of my knee. Was there any history of trauma? You can ask this question in the differential diagnosis, and you can ask it in the past medical history. I used to ask it in the differential diagnosis because this will let the examiner know that you know what is the osteoarthritis and what is the causes and risk factor of osteoarthritis. So you need to mention this question in the differential diagnosis of the osteoarthritis. The second differential diagnosis is anterior cruciate ligament injury. Here you know your differential diagnosis. So go fast as can as possible through other differential diagnosis. Mr. Adam, did you experience your knee giving away while walking? No, I haven't experienced any giving away sensation in my knee. Meniscal injury. Do you experience locking of your knee? No. Rheumatoid arthritis, which you can detect it by the stiffness in the morning, and you can ask, have you noticed any stiffness in your joint when you woke up in the morning? I have noticed significant stiffness in my knee throughout the day. Stiffness is also sign of osteoarthritis, but stiffness in the morning is a sign of rheumatoid arthritis. The 5 differential diagnosis is septic arthritis. Knee pain, the long station, have many differential diagnoses. So you need to be fast. Mr. Adam, have you noticed swelling of your knee, redness, any discharge? My knee has been slightly swelling and sometimes it looks a bit reddish, but there is no discharge. And the last 2 differential diagnosis is the spine, and the last 3 differential diagnosis is the spinal cause, which you can clarify it by asking about the numbness or weakness in the legs and back pain. Have you noticed weak or numb legs? Do you have back pain? I haven't noticed any weakness or numbness in my leg. And while I have occasional lower back pain, I don't think it is related to my knee pain. Here, he mentioned that back pain not related to knee pain. So I will not go in details of the back pain. Inflammatory bowel disease. Have you noticed any rash anywhere on your body? No, I haven't noticed any rashes. Did you notice any change in your bowel habits? I have no any change in my bowel habits. This 2 minutes, I would like to mention about inflammatory bowel disease. You have to choose if to ask any question about the inflammatory bowel disease, and to make it easy, start from head. Patient having inflammatory bowel disease have redness, painful eyes. Go down, you will find rash in his neck and his chest and all of his body. Then go to the joint, you will find joint pain, and then down to the bowel, which you will find change in bowel habits as constipation or diarrhea. You can ask about 2 questions because your main diagnosis already stabilized, which is the osteoarthritis. The last differential diagnosis is the malignancy. You can detect it by 2 questions, the appetite and the weight. Mr. Adam, have you noticed any significant weight loss over the past few months? How is your appetite? Ask this question separately, please. Don't ask 2 questions together. In the past medical history, you need to ask about 3 important things, which is the similarity, previous similar condition, second thing, chronic condition, third thing, history of surgery. Here, the most important questions, this patient have surgery, have osteoarthritis. The most important question here to ask about history of surgery before. If you have no time, please ask these questions. Family history, similar as past medical history, any similarity, any chronic disease. Drug history has 2 questions, which is the long-term medication or regular medication, and allergy. Do you take any medication? I'm currently taking some over-the-counter pain reliever, occasionally for knee pain, but no prescription medication. Fine. Do you have any allergies? I don't have any non-allergies. The social history. In social history, also there are some important questions that are mandatory to ask, which is smoking and alcohol consumption, as Ali said previously. But to be more systematic, ask about his occupation first and with who he or she lives. The last, before last, the idea, I will review the question. Do you mind if I ask you a personal question, Mr. Adam? No problem at all. What is your occupation? I work as a receptionist at a local office. Who is at home with you? I live alone. Do you have any difficulty with the stairs? Yes, I have some difficulty with the stairs because of the knee pain. Be alert about choosing your question according to your time. Here in the knee pain, do you have any difficulty with the stairs? Is the most important question in the social history. Idea, concern, and expectation. Eyes. Systemic review. For systemic review, if you have time, go quickly through it. If you haven't, don't worry. It is not a crucial point. And to make it easy, start from head. Ask about the main symptoms in every system. In the CNS, do you have a headache? In the chest, any chest pain or shortness of breath? In the respiratory also. Any belly pain? In the gastrointestinal? Any problem with any urinary? Muscle joint? Musculoskeletal? Any muscle or joint pain? No, I haven't experienced muscle or joint pain beside my right knee. And anything else you would like to add, Mr. Adam? At the last, as I said, the 5 concepts which you need to thank the patient at the end of the session. In the discussion, when the examiner asks you present your case, please be systematic. Start by patient name and age. As I took clinical history from Mr. Adam is a 56 years old male who reported persistent and worsening pain localized to the right knee, which began gradually in the last month, occasionally sharp stabbing sensation, rated around 8 to 10, impacting daily activity and increasing in intensity during the evening and at night. Here you give a clue about the complaint of the patient and details. Then you will need to give information to support your diagnosis, which is the osteoarthritis that you will mention at the end of your presentation. He had a history of right knee injury several years ago. Also, he had a history of right knee surgery. Here, you support your diagnosis. Patient have stiffness and neurological symptoms were not observed. So my main differential diagnosis is traumatic osteoarthritis. As Ali said, in case if you miss the patient name or forget the patient name and age, say I took clinical history from this gentleman who presented with worsening pain localized, blah, blah, blah. The examiner will ask you what is your other differential diagnosis. Mention all differential diagnoses that excluded in your history. Meniscus injury, anterior cruciate ligament injury, rheumatoid arthritis, septic arthritis, till the malignancy. And the examiner will ask you, how will you investigate your patient? Some examiner will ask you how to manage this patient. In management, the first things you need to mention is examination, then investigation. Make sure to mention most important investigation. And last thing is the treatment. As the examiner asks me how to treat this, how to manage this patient or how to investigate this patient, I will start by doing full clinical examination of the knee joint. Then I will request, it will be better if you categorize your investigation into blood investigation and imaging or what else. But if you have no time, please mention the most important investigation. In the knee station, which is the longest station, so start by imaging. I will request weight bearing knee X-ray, anterior posterior and lateral view, MRI, magnetic resonance imaging to evaluate soft tissue, ligament, and meniscus, blood test, full blood count, and inflammatory marker, and joint aspiration to rule out any septic arthritis and to analyze synovial fluid. How you will treat this patient? Categorize your treatment into conservative management and medical intervention and surgical intervention. The conservative management for patient having osteoarthritis, analgesia, heat application, achieve and maintain health weight, regular exercise, physiotherapy, assistive devices. And the medical intervention, intra-articular steroid injection. And the surgical option is arthroscopy. You can say just arthroscopy. You don't need to mention arthrocentesis or realignment, osteotomy, or total or partial knee replacement. By arthroscopy, you can do arthrocentesis, realignment, osteotomy, and total or partial knee replacement. As the last, here we find timetable about the differential diagnosis and most important questions regarding every differential diagnosis. Scenario, an elderly man who has package, introduce yourself and take permission. Hello, I am Dr. Minallah, one of the surgical doctors. May I confirm your name and age, please? My name is Jack. I am 45 years old. Nice to meet you, Mr. Jack. Today I will be your doctor. Is that okay with you? Here you take the permission with the second concept. Go ahead, doctor. Mr. Jack, how can I help you today? I have this back pain. So here's the point to show empathy and feel sorry about the patient back pain. I'm really sorry to hear that, Mr. Jack. Analyze the main complaint, which is back pain, by using Socrates. Where exactly do you feel that pain? In the lower part of my back. Mr. Jack, could you please point to the side? Here, doctor, in the lower part of my back. When you ask the patient about where the pain, if mentioned in the lower part of my back, you need to clarify more by pointing the side of the pain. Here side, and onset, did it start suddenly or gradually? Does it present all time or come and go? It is gradually, it come and goes. Then the character of the patient. Could you please describe the pain for me? Is it colicky, dull, crushing, cramping, or stabbing? You need to clarify the description of the pain to make it easy for patient to answer. It is dull pain. Mr. Jack, does it move anywhere else? Here is the radiation. No. Association. Does anything make it worse or better? I feel pain when I walk. And then the rating of the pain in a scale of 1 to 10, 1 being the lowest pain and 10 being the highest pain. How could you score this pain? Around 7. Here in the differential diagnosis, as we told previously, you need to ask about your top differential diagnosis first and go fastly through the other differential diagnosis. Mechanical back pain with the top differential diagnosis. Mr. Jack, have you had a recent trauma to your back? No. Have you had history of heavy lifting? Yes. Here you confirm your diagnosis, but it's mechanical back pain. Now go fastly through the other differential diagnosis. Coda eguina or cord compression. Mr. Jack, do you have weakness at your leg? Before starting question, this is coda eguina and cord compression about neurological symptoms. So ask about weakness, numbness, and any problem in waterwork or bowel. Mr. Jack, do you have weakness at your leg? No. Do you have numbness at your legs or numbness at your genitalia? No. Do you have any problem with your waterwork or bowel? No. Mr. Jack, have you had any difficulty in gaining an erection? No. The third differential diagnosis is malignancy. Did you experience any weight loss, any loss of appetite? We wrote this question together, but in the exam, please ask separate questions, okay? Did you experience any weight loss? No. Any loss of appetite? No. The fourth differential diagnosis, because this back pain may be post disease. Mr. Jack, do you have a cough? Because it's the tuberculosis. No. Do you have a fever? No. Any night sweats? No. You exclude the post disease. Then ankylosing spondylitis, which is the stiffness at the morning. Mr. Jack, did you experience any stiffness in your back at the morning? No. Osteoporosis. Did you have any bone fracture that occur more easily than expected? No. Then past medical history. Did you experience similar symptoms? No. Mr. Jack, do you have any other medical problem or chronic condition? No. Do you have any history of surgery, operation? No. The family history, same as past medical history. You need to exclude similar condition and exclude any chronic condition like hypertension or diabetes. Is there any else in your in the family had a similar problem? No. Drug history, long-term medication and allergies. Mr. Jack, do you take any regular medication? No. Do you have any allergy against any drug? No. Social history. I would like to ask you personal questions. Is that okay with you? Okay, go ahead, doctor. Mr. Jack, what do you do for a living? Here, this is an important question because patient having back pain. I work at our house. Do you have any difficulties?
So as Muhammad said, asking about the occupation here is the most important thing because his occupation determines his mechanical back pain.
Okay, yeah.
So he's working at warehouse. That means he's taking heavy stuff on his back. That's why it is a very important question to ask about.
Do you have any difficulty using stairs? Yes. Also, this is an important question. And do you smoke? No. Do you drink alcohol? No. This is the less important question here. The idea, concern, and expectation. Also, it will give you a clue about the patient concern. And here you can show your empathy and feel sorry about the patient, and you will get the mark of the full communication skills. What do you think the cause is? I don't know. What are you the most concerned about this pain, Dr. Mr. Jack? You need to mention your patient name frequently, okay? What do you hope from us to do for you? Figure out and help me. Here, the embassy. Don't worry and reassure. Don't worry, we will take care of you. As we say, systemic review. If you have a time, go through it as quick as possible. And if you don't have a time for it, don't worry. not a crucial point. Do you have a headache, shortness of breath, chest pain? No, no, no. Mr. Jack, are you aware of your heartbeat? No. Do you have any problem in your water work? Any muscle or joint pain? No. Anything else you want to add? No. Thank the patient, and the examiner will ask you, present your case. I took clinical history from Mr. Jack, a 45 years old, presented with lower back pain. Here I mentioned name, age, and pain complaint. Started 1 month ago, gradually, and getting worse recently. The pain is dull in nature and increase with movement. Here I give details about the main complaint. He work as a weight lifter and his work require heavy lifting. Here I give a point that support patient having mechanical back pain. No symptoms suggestive of Coda iguana syndrome or malignancy. Here I mention no symptoms suggestive because Coda iguana syndrome and malignancy is a serious differential diagnosis. So I mentioned it by no symptoms suggestive of Coda iguana syndrome or malignancy. So my main diagnosis is mechanical back pain. The examiner will ask you, what is your differential diagnosis? Say the differential diagnosis that excluded in your history: Coda iguana syndrome, malignancy, post disease of the spine, osteoporosis, ankylosing spondylitis. What is your management? What is your investigations? How to deal with this patient? All share same meaning. What is your management? Start by full clinical examination. I will do full clinical examination, including back examination, anal examination, lower limb neurological examination. Here you have 3 examinations because back pain related to the anal condition and related to the lower limb neurological examination. Then I will request, after examination, go to the investigation. Blood investigations, which is a full blood count to estimate hemoglobin and white blood cells. Inflammatory marker like CRP and ESR. Liver function test, urea and electrolyte. Imaging, which is the most important investigation, you need to do it. If you have no time, skip the blood investigation at the end and mention the imaging, which is a lumbosacral X-ray, anterior, posterior, and lateral view. Urgent MRI scan if cord compression or Coda iguana is suspected, because Coda iguana need urgent intervention. DEXA scan if a crush fracture is suspected. This DEXA scan is the first one. And the chest X-ray, and mention the chest X-ray and quantiferon TB, because you mentioned the differential diagnosis above, which is Bot's disease. So you need to exclude it by mentioning investigation related to it, if TB is suspected. Quantiferon is the gold standard test for TB. The examiner will ask you, what is your treatment? Your top differential diagnosis is the functional back pain. Simple back pain, I will give analgesia for the pain. Refer to the social worker is the most important, because the patient, his job make him difficult to work again. So refer the patient to the social worker. Regular exercise, physiotherapy. Consider short course muscle relaxant. The examiner will you will not mention the cord compression and cord iguana syndrome. I will treat it by blah blah blah. No, the examiner will ask you, if this patient have cord compression and cord iguana syndrome, what's your management? So the management of cord iguana syndrome is dexamethasone and act as anti-inflammatory, reduce neutrophil and inhibit the inflammation. So dexamethasone, urgent surgery decompression by laminectomy or disectomy. And also the examiner will ask you, if you suspect malignancy, what's your management? Radiotherapy. This is also timetable for the differential diagnosis of the back pain, with the related most important question that you can differentiate it from each other. Here, haematuria, an elderly man with blood in urine. You'll find more about the scenario, but the main point is elderly man with blood in urine. The first differential diagnosis in my head, this is the elderly man, blood in urine. I think it is malignancy. So introduce yourself and take and ask for permission. Hello, my name is Muhammad. I am one May I confirm your name? I am one of the surgical doctor. You can mention it. May I confirm your name and age, please? Hello, I am Anderson. I am 65 years old. Nice to meet you, Mr. Anderson. Today I will be your doctor. Are you okay with this? Here you introduce yourself. You take the permission. Yes, that's fine. How can I help you today? Well, I have been experiencing blood in my urine, and I am a bit concerned. Analyze the main complaint. I am sorry to hear that. When did you first notice this blood, which is the onset? It started a month ago. Mr. Anderson, does this bleed start suddenly or gradually? It starts gradually. It's also about the onset. Does it come and go? It seems come and go. It's also about the onset. Does it getting worse? It has gotten worse recently. What is the color? It is red. You can say same like the character of the blood. What is the color? It's the red. Mr. Anderson, is there anything that make the bleeding stop or increase? It's also about the association. So Socrates can work with any history station. No. Is the blood present at the start, end, or throughout urination? It's mainly throughout urination. Do you pass any clothes? No clothes. Have you recently eaten any beetroot? No, I haven't had beetroot recently. Here, the differential diagnosis. Malignancy, you can exclude it by main two questions about weight loss and appetite. Mr. Anderson, how has your appetite been? I have no appetite. Have you noticed any unintentional weight loss? I have lost 10 kilos unintentionally in just 4 months. Here another question. Did you experience any general tiredness? Yes, doctor. I feel tired all the time. Also, it give a point to the malignancy differential diagnosis. In patient with haematuria, also the second most important to exclude benign prostatic hyperplasia. You don't need to mention all the question about the benign prostatic hyperplasia. You can touch just 2 to 3 questions and go to the next. Do you go to the law, Mr. Jack? Do you go to the law more than usual? No, doctor. Do you get sudden urge to pass urine? No. Mr. Anderson, sorry. Do you have difficulty getting the stream started, prolonged dribbling at the end? Yes, there's sometimes difficulty starting and there's prolonged dribbling. Ask this question separately, please. The third differential diagnosis is the infection. Have you been unwell recently or had any fever or chills? No fever or chills. Trauma. Have you had any trauma to your tummy or growing recently? No recent trauma. Past medical and surgical history. Mr. Anderson, did you experience similar symptoms before? No. Were you diagnosed with any medical condition? I don't have any medical condition besides this. Have you ever had a surgery? No. You can add the questions about have you ever had a history of recent catheterization? Family history, same as past medical history. Is there anyone else in your family who has had similar problem? No one I am aware of. Drug history. Mr. Anderson, do you take any medication? And do you have any allergies? I'm not on any medication and no allergies. Need to exclude bleeding tendency. We forget that. You need to ask the patient, is there any bleeding from other orifice of your body? Do you take any blood thinner medication? Social history. Do you mind if I ask you some personal questions? Go ahead, doctor. What is your occupation? I work as an accountant. What is who is at home with you? I live with my wife and 2 kids. Mr. Anderson, do you smoke? And if so, how many packs per day? I don't smoke. Here, and smoking can be trigger for malignancy and be risk factor. Do you drink alcohol? No. You can ask this question separately. Sorry, please ask this question separately. Do you drink alcohol? No. If yes, how many units per week? I drink occasionally. 2 units per week. Do you have any difficulty with the stairs? No difficulty with the stairs. Thank the patient. Go to the eyes, which are the idea, concern, and expectation. Systemic review. Do you have a headache? No. Have you experienced any palpitation, chest pain, or shortness of breath recently? No. Ask this question separately. I haven't noticed any palpitation, chest pain, or shortness of breath. Have you had a cough, difficult breathing, wheezing? No, I haven't had any cough or difficult breathing or wheezing. Are you experiencing any stomach pain, changes in bowel habits? My digestion has been normal and I haven't experienced any stomach pain or changes in bowel habits. Mr. Anderson, have you observed any rash, itching, or unusual changes in your skin? My skin has been normal without any rashes, itching, or unusual change. Thank the patient. In the discussion, the examiner will ask you how to present your case, please. I took a clinical history from Mr. Anderson, 65 years old, presents with painless total hematuria, weight loss, he lost 4 kilos in the last month, anorexia, and a work history in a dye factory. So my main diagnosis is bladder cancer. What is your differential diagnosis? Put the benign prostatic hyperplasia, the second differential diagnosis, UTI, urinary stone. How to manage this patient? We said you need to start by full clinical examination. Here you need to add digital rectal examination because you have benign prostatic hyperplasia as the differential diagnosis. So you need to differentiate, this is prostate cancer or it is benign prostatic hyperplasia. Then mention the investigation. Accordingly, urine dipstick, the first investigation, no matter what is important or not, first investigation is urine dipstick. Why? To confirm the hematuria. Assess infection and send the sample for cytology. Blood test like full blood count, urea electrolyte, inflammatory marker, prostate-specific antigen. Cystoscopy and biopsy for detailed examination. An imaging study like ultrasonography and CT scan. How you treat this patient? I will discuss him first in the MDT meeting, but in general, to approach depends on the stage and grade of the tumor. Surgical options include transurethral resection of bladder tumor and radical cystectomy. Non-surgical methods encompass chemotherapy, radiotherapy, and immunotherapy. After that, you can thank the patient or the examiner will thank you, doctor. You can proceed to the next station.